Hello everyone, it's my pleasure and a great honor to share with you this very important lecture about my. Our agenda will include introduction, classification, diagnosis, and the differential diagnosis of myocarditis. Let's start with short introduction. Myocarditis is a significant cause of sudden death and non-ischemic dilated cardiomyopathy, especially in the young. It has a very diverse and sometimes non-specific presentation and can mimic various disease entities. Myocarditis is caused by a variety of infectious and non-infectious conditions. Although viral myocarditis is the most common type, non-viral myocarditis also must be considered. In the last few years, COVID-19 has emerged as an important etiology of myocarditis from both direct infection and immune reactions. It has also been connected to a reaction to specific SARS-CoV-2 vaccines. In addition, many inherited cardiomyopathies, including Fabry's disease and arrhythmogenic right ventricular cardiomyopathy, may present with features of acute or chronic myocarditis. Let's go for classification of myocarditis. Myocarditis can be classified into acute form and chronic form. Acute form include fulminant myocarditis and acute myocarditis. Chronic form include chronic active myocarditis and chronic persistent myocarditis. Let's start with the profiles of acute myocarditis. Among patients with myocarditis who present with acute symptoms and signs of cardiovascular disease, the presentation may be variable. Key clinical profiles were described by the European Society of Cardiology position statement on myocarditis into the following categories. The first one is acute coronary syndrome-like presentation. The second one is new onset or worsening heart failure. The third one is life-threatening condition such as life-threatening arrhythmias, aborted sudden cardiac death, cardiogenic shock, or severely impaired left ventricular function. And finally, patients with acute myocarditis with associated pericarditis. Let's start with the acute coronary syndrome-like presentation. Patients with acute myocarditis may present with acute coronary syndrome-like, with acute chest pain in absence of angiographic evidence of coronary artery disease. The acute chest pain frequently starts within 1 to 4 weeks after respiratory or GIT infection and is frequently associated with severe and recurrent symptoms. In this type of patients, we will observe ST segment changes and T wave changes in form of ST segment elevation or ST segment depression and T wave inversion. By imaging, global or regional left ventricular and or right ventricular dysfunction may or may not be detected. Biomarkers troponin T or troponin I may or may not be elevated. The time course of troponin elevation may be similar to that with acute MI, or may be prolonged and sustained over several weeks or months. The second presentation of acute myocarditis is new onset or worsening heart failure in absence of coronary artery disease and in absence of a known cause for heart failure. They can present with new onset or progressive heart failure over 2 weeks to 3 months, with symptoms including dyspnea, peripheral edema, chest discomfort, and fatigue. We can notice impaired left ventricular and or right ventricular systolic function. Left ventricle and or right ventricle may or may not be dilated. The wall thickness may or may not be increased as assessed by echocardiography or cardiac MRI. Some patients with ventricular dysfunction may progress to dilated cardiomyopathy. The symptoms may start also after respiratory or GIT infection or in the peripartum period. The ECG may show non-specific changes or bundle branch block or EV block or even ventricular arrhythmias. The third presentation of acute myocarditis is life-threatening condition in absence of coronary artery disease and in absence of a known cause of heart failure, with one of the following scenarios. Life-threatening arrhythmias, including ventricular arrhythmia, aborted sudden death, severely impaired left ventricular function, and cardiogenic shock. The final presentation of acute myocarditis is myopericarditis or perimyocarditis, and these patients may present with positional or pleuritic chest pain with evidence of pericardial effusion. Let's move to chronic myocarditis. Some patients with myocarditis present with insidious onset of illness developing over more than 3 months, which has been described as chronic myocarditis. The chronic myocarditis is subclassified into chronic active and chronic persistent myocarditis. Let's start with chronic active myocarditis, which is characterized by frequent clinical and histological relapses and, importantly, ventricular systolic dysfunction, with evidence of chronic inflammatory changes and mild to moderate fibrosis on endomyocardial biopsy. While the second category of chronic myocarditis is chronic persistent myocarditis, which also characterized by persistent histological infiltration with evidence of myocardial necrosis, but with preserved ventricular function, and persistent chest pain or palpitation. Let's move to diagnosis of myocarditis. The first question is when to suspect myocarditis. Myocarditis should be suspected in patients with or without cardiac symptoms and signs, who have a rise in cardiac biomarkers, namely troponin, and ECG changes suggestive of acute myocardial injury or arrhythmia or global or regional abnormality of the left ventricular systolic function, especially if the clinical findings are new and unexplained. Clinical suspicion for myocarditis should be high in patients who present with clinical symptoms and signs of acute MI, especially if the patient lacks cardiovascular risk factors for coronary artery disease or the coronary angiogram is normal. In this setting, myocarditis should be also differentiated from stress or Takotsubo cardiomyopathy. Finally, we have to suspect myocarditis in patients with pericarditis who have also evidence of elevated cardiac biomarkers. The second question is how to diagnose myocarditis. We have two categories of patients. The first one is definite myocarditis and the second one is clinically suspected myocarditis. The diagnosis of myocarditis is definitively established in patients who have diagnostic findings by the Dallas criteria on endomyocardial biopsy. What about the clinically suspected myocarditis? For patients who don't undergo endomyocardial biopsy or haven't diagnostic finding on endomyocardial biopsy, the definitive diagnosis can't be established, but a diagnosis of clinically suspected myocarditis may be made if the diagnostic criteria are met. So, what are the indications of endomyocardial biopsy? The indications of endomyocardial biopsy include progressive or persistent severe cardiac dysfunction associated with life-threatening ventricular arrhythmia or associated with second degree or complete heart block with lack of short-term expected response to the usual medical treatment within 1 or 2 weeks. The aim is to identify the etiology and to indicate the specific treatment such as giant cell myocarditis, eosinophilic myocarditis, cardiac sarcoidosis, and finally systemic inflammatory disorders. How to diagnose clinically suspected myocarditis? The patient has clinically suspected myocarditis if there is one or more of the clinical presentations with one or more of the diagnostic criteria. If the patient is asymptomatic, we must have two or more of the diagnostic criteria, but from different categories. The diagnosis of clinically suspected myocarditis also require the absence of other clinical conditions that could explain the clinical findings, such as angiographically significant coronary artery disease with coronary stenosis 50% or more, valvular heart disease, congenital heart disease, or even extra cardiac condition such as hyperthyroidism. So, what are the clinical presentations and what are the diagnostic criteria? The clinical presentation include acute chest pain, which can be pericarditic or pseudo-ischemic. Number 2, new onset or acute or even chronic heart failure. Number 3, arrhythmias in form of palpitation, syncope, or aborted sudden cardiac death. And finally, unexplained cardiogenic shock. The diagnostic criteria include newly abnormal 12-lead ECG or Holter, elevated biomarkers such as troponin T or troponin I, new and otherwise unexplained functional and structural abnormalities on cardiac imaging, and finally tissue characterization by cardiac MRI, including myocardial edema and the characteristic late gadolinium enhancement pattern of myocarditis. The last part of our lecture is about the differential diagnosis. Myocarditis can mimic several conditions, so we must carefully consider its differential diagnosis. When a patient presents with suspected myocarditis, the differential diagnosis include: number 1, other conditions with similar symptoms and signs, and other causes of myocardial injury, including ischemic heart disease and stress cardiomyopathy, and finally other types of cardiomyopathy. Echocardiography is very helpful tool for differentiation of many of these disorders. What are the other causes of myocardial injury that can mimic myocarditis? Ischemic heart disease, mainly acute coronary syndrome, stress cardiomyopathy, coronary vasospasm. What are the other conditions that may present with similar symptoms and signs to myocarditis? Infective endocarditis, pericarditis, ventricular tachycardia, or even non-cardiac causes including interstitial pulmonary fibrosis or high altitude induced pulmonary edema. What are the other types of myocarditis that can mimic myocarditis? Hypertrophic cardiomyopathy, restrictive cardiac syndromes such as cardiac amyloidosis, ischemic heart disease, peripartum cardiomyopathy, right ventricular myocarditis can present like ARVC. How to differentiate between myocarditis and acute coronary syndrome? Myocarditis may present similarly to ischemic heart disease with chest pain, ECG abnormalities, elevated cardiac biomarkers, with regional or global LV dysfunction. Coronary angiography is indicated in selected patients with clinical findings suggestive of coronary artery disease to help to differentiate ischemic heart disease from myocarditis. Cardiac MRI is very helpful in differentiation between ischemic heart disease and myocarditis by the characteristic pattern of late gadolinium enhancement. In patients with myocardial infarction, we have evidence of either transmural late gadolinium enhancement or subendocardial late gadolinium enhancement. While in patients with myocarditis, we will find the distribution of late gadolinium enhancement either subepicardial or mid-wall. How to differentiate between myocarditis and Takotsubo cardiomyopathy? Takotsubo cardiomyopathy may present with symptoms and signs similar to myocarditis. However, the pattern of wall motion abnormality most commonly seen in the stress cardiomyopathy, typically left ventricular apical ballooning or dysfunction, and less commonly mid-ventricular or basal, are generally not seen in myocarditis. Recovery of ventricular function with Takotsubo cardiomyopathy is generally more rapid than myocarditis. Patients with stress cardiomyopathy or Takotsubo cardiomyopathy commonly recover within 1 week and generally within 4 weeks. Cardiac MRI also will be helpful since signs of myocardial inflammation and scar, which are typical for myocarditis, are generally absent in patients with Takotsubo cardiomyopathy. How to differentiate between myocarditis and the other types of cardiomyopathy? The inflammatory phase of several inherited arrhythmogenic cardiomyopathy, including arrhythmogenic right ventricular cardiomyopathy, may present with myocarditis with or without sudden death. And this highlights the importance of family history and the pedigree analysis and genetic testing to ascertain the underlying cause in patients with myocarditis, especially as relatives may be at risk. So my final take-home message is myocarditis should be suspected in patients with or without cardiac symptoms and signs who present with rise in cardiac biomarker levels, a change in the ECG suggestive of acute myocardial injury, arrhythmia, abnormalities in ventricular systolic function, especially if these clinical findings are new and unexplained. The diagnostic evaluation of patients with suspected myocarditis should include physical examination, lab testing, cardiac imaging, endomyocardial biopsy when clinically indicated. Definitive diagnosis of myocarditis is based upon the Dallas criteria obtained from the endomyocardial biopsy. When a patient presents with suspected myocarditis, the differential diagnosis include other conditions with similar symptoms and signs, other causes of myocardial injury, and other types of cardiomyopathy. Echocardiography and cardiac MRI is very helpful for differentiation of many of these disorders. These are our references. Thank you so much.